Hello, I'm Nashya Haider, the founder of Innotech Consultants. Today we have the great pleasure of speaking with Dr. Robin Edwards, who's a senior consultant gynecologist here in Singapore at Raffles Hospital. Hello, Robin. It's lovely to meet you today for our podcast.
It's a pleasure to be here.
I'd like to start on the topic of women's health. Many women experience major life transitions, such as menopause, perimenopause, with limited support. What do you feel are the most misunderstood aspects of menopause, and how should healthcare systems address them?
Yeah, it's a great question. And menopause and perimenopause particularly are increasingly talked about freely. Women are very keen to learn more about it. And doctors like me and other gynecologists and other healthcare professionals more generally are ready to discuss those symptoms with women. It's an important topic because all women will go through menopause. The average age is between 50 and 51. And the majority of women going through menopause will experience symptoms. So symptoms may be mild. Some women might stop their periods and never have one ever again and not experience anything too significant associated with that. But the majority will face challenges as they approach menopause. So that might mean a change in their menstrual cycle. They may experience infrequent cycles, or they may have irregular pattern of bleeding. They may have heavier periods. They may experience pain. And they may have other associated symptoms like a change in sleep pattern, hot sweats, and disruption to their day-to-day life, maybe mood changes or difficulties at work. And so we discuss those factors and individualize our advice depending on what the particular symptoms are. It's estimated that between 70 and 80% of women will have symptoms that they are troubled by, so symptoms that really affect their quality of life. And it's important that those women feel able to discuss those with not only their friends and family, but also with healthcare professionals who can then help guide them through. In terms of what the healthcare system can offer, I think it's important that women know who to go and discuss with, and that when they choose a doctor or other healthcare professional to talk about their symptoms, that person also feels enabled to have the discussion. So they feel confident in the advice that they're giving to patients, that it's up to date, that it's relevant, and that they don't bring their own biases into the discussion. Because sometimes that can be an important factor in whether women actually engage in the first place, or whether they actually take on the treatment and advice that is offered. So it's very important that you have organizations that are able to collate data, research, and offer the best advice that we can. So we try and maintain our skills and our knowledge by having regular updates as part of our continuing medical education.
That's fantastic advice. Thank you so much for that. Following on from that, I was talking about, I'd like to find out something about routine screenings, such as pap smears and mammograms, because early detection saves lives. Yet access and uptake vary widely in the society. What factors influence whether a woman gets screened?
Another great question, and something that we grapple with sometimes, is how do we invite women for screening programs, and how do we make sure that we're screening enough women, that we're detecting disease early and hopefully preventing the consequence of that disease. And pap smears and mammograms are both good examples of where early detection can really make a difference to prognosis. That is survival rates, but also quality survival. So with reduced morbidity, reduced effects of treatment. In terms of access, we have to make sure that women understand what those tests are. So we use terms quite freely like pap smear, and we assume that women know what that means. But in my experience, when you discuss that with some women, they won't really understand what it is, how the test is done, and what the purpose is. Is it a test that's going to tell you if you have cancer or not, or is it screening for abnormalities in the cervix? So it's really important that we are clear with our patients why we're recommending a test and what we expect to gain from that test. And the same with a mammogram. So a mammogram is a special type of X-ray, which is a picture of the breasts, and it's looking for abnormalities in the breast tissue as seen under X-ray. It's not a test that is universally appropriate, so for different age groups of women it may be more or less accurate. So a mammogram in a younger woman may not be as accurate as a mammogram in an older woman post-menopause. So with younger women we do use mammograms, but we also additionally use ultrasound, and in some parts of the world they're using MRI scanners also to check breast tissue, particularly in younger women, because it may add some accuracy to the test. So screening is generally well accepted in populations like Singapore, where it's offered quite freely. Often as part of employment, people will be invited to go for an annual checkup. But some people won't be aware, and it's important that information is available not only in English, which is widely spoken, but also other languages that people might feel more comfortable conversing. So the government actually here has a program called Screening for Life, which puts out information on the internet for people to access, and shows people quite clearly how to have their test done and what to expect when they have it. So that's a very useful scheme. And in other parts of the world, there'll be very similar schemes. Screening has been around for cervical cancer for around about 50 years or so in various forms. But to answer your question about how do we maximize the benefit from that, how do we ensure that the people that require screening come forward for screening, we have to make that screening test acceptable. And so women have to know what is going to happen when they come for their appointment, have the option to say, yes, I would like that, or no, thank you, I don't want that test done to me, and then know what we do with the information that we gain from it. So they have to have confidence in the scheme. They have to know that the test is going to be done professionally. They have to know that the result is going to have a certain accuracy and a certain inaccuracy about it, and then what follows on from an abnormality. In the case of pap smears, it's a test that's been around for about 100 years. So the pap smear comes from the name Papanikolaou. He was a Greek physician working in Cornell University in the States. And he discovered the natural history of the cells within the cervix and how they correlate with the development of cervical cancer. So his and various colleagues working around the same time discovered that if we detect early changes in the cells, then we can predict who is more likely to develop cervical cancer and treat them at the point where they have early stage disease. And so with his knowledge and the general acceptance of the test, it's been able to save hundreds of thousands of lives since it was introduced. So a great success story for screening. We also nowadays have additional tests that we can add to the pap smear, the smear test, which is a traditional test where we look at the cells under the microscope in the lab. But we now have the ability to test for something called HPV, which is the human papilloma virus. And with the knowledge that we have about how cervical cancer develops, we know that almost all cervical cancers are related to HPV. So if we add an HPV test to a pap smear, we increase the accuracy of the test, not only to detect the women at most risk of cervical cancer, but also reassure those at very low risk of cervical cancer that they don't need to have excessive screening tests or over-treatment of minor abnormalities which will resolve by themselves. So over the years, over the decades since that test was first invented, we've been able to progress things and evolve the test to become even more accurate and reliable. So yeah, I would encourage women who have access to screening to take it up. To those that don't have access to screening, to lobby their politicians to increase access. And there'll be parts of the world where there is no screening for cervical cancer. And in those countries, we see rates of cervical cancer persist, and the treatment is at late stage. And unfortunately, women are still dying in the developing world from cervical cancer, which is entirely preventable.
So, Robin, at what age would you advise a young lady to start doing cervical cancer screening?
It's a great question, and something where you'll get a bit of controversy in the answer. So, and the reason for that controversy is that we want to maximize the detection of precancer of the cervix, which would otherwise have led on to the development of cancer. So you would think that detecting that in the early age group would be a good thing, and you'd reduce cancer rates. But what has been discovered is that actually lots of young women will have minor abnormalities in the cervix. So they'll have an abnormal pap smear result perhaps, and that will lead on to investigations and perhaps lead on to over-treatment of a condition which would never have led to cervical cancer. So you can easily detect minor abnormalities which improves the accuracy of the test, for sure, but not necessarily saving lives or reducing cancer rates. So in the UK, where I used to work before and where I trained, the age of first invite for a cervical cancer screening test was moved from age 20 to age 25. And the rationale for that was to minimize over-treatment but maximize cancer detection. Now, in amongst that, you will miss a few cases potentially of perhaps aggressive cervical cancers or women who are unfortunate enough to have developed those abnormalities earlier in life and they progress in those intervening years. But the purpose of a screening test is on a population level. So it's designed to be offered to a population to reduce the overall cancer rates. It's not an individual test that an individual person is going and seeking. So governments and healthcare organizations which set up screening tests always have to weigh up the potential for a waste of resource. So you focus your resource on people that aren't at risk of the endpoint disease, in this case cervical cancer, versus the benefit of picking up those few cases. So to answer your question, in Singapore, the recommendation is age 25.
Okay.
And that is on the assumption that the woman is sexually active by the age of 25. The reason that assumption comes in is because we know HPV is the cause of cervical cancer, and HPV is passed through sexual contact. So if someone is not sexually active at the age of 25, they're at very low risk of having picked up HPV, and therefore at very low risk of having cervical cancer or pre-cancer. So offering those women cervical cancer screening test is probably not appropriate given how the test is done, which is through a vaginal examination. So 25 is the age group in sexually active women. And then on a regular basis, which varies from country to country, until later years, perhaps age 65, 70, again, depending on the country. So you're picking up cases throughout the woman's lifetime where the cervix is changing and the cells are becoming abnormal. And we know a lot about cervical cancer history and how it develops. We know it's generally a slow developing progressive abnormality. So we can detect those early stage changes, we can monitor. Sometimes they'll get better by themselves and resolve, and sometimes they will progress onto more advanced disease, which can then be treated. So cervical cancer screening is a really great success story. And if women come forward at the age when they're invited, or if they're able to access screening programs, then we know it saves lives.
Fantastic. Thank you so much for that information. I mean, this is very educational for younger women as well, to educate them to go ahead and do the preventative healthcare screening. Yes. And in some parts of the world, women and girls still face significant hardships or barriers to access to even basic healthcare. So what needs to change in, for example, policy or culture to ensure equitable access, in your personal view?
So I mean, it's a difficult question, isn't it? Because each country has a very different view on healthcare, how it's provided, to whom it is provided, and how people access healthcare. So each country has to design their system according to their population's needs. For women and girls, access to healthcare can be less available than it is for their male counterparts. And in some cultures, that is definitely the case. Priorities are perhaps different for certain cultures. And women may find themselves in a less independent position, so they may have no financial independence to seek out healthcare if there's a financial commitment to receiving healthcare. They may not have the ability to maybe travel independently to a health service. There may be certain taboos, particularly when it comes to gynecology, sexual health, screening for cervical cancer, there may be certain restrictions on how people are able to express themselves or seek help. And that can be on the part of the provider, the doctor or the healthcare professional as well. And so women face those difficulties in certain parts of the world. In developed nations, you may not have such extremes, but there may be structural biases within society whereby things like, conditions like the menopause may not be acknowledged as being a medical problem. So they're seen more as a lifestyle problem, which is false, but that can then lead into availability of care, because certain, say, insurance policies might exclude that provision. And we see that a lot in Singapore, that people have good healthcare insurance, but there's certain conditions, including menopause, which just aren't covered. So hormone replacement therapy might be an exclusion on a policy, and that's quite common. So in that sense, women are freely able to access healthcare. They can see a doctor just as easily as a man can, but they can't access the high quality care that they need because of the financial limitation on their policy. So they have a choice. They can pay out of pocket. They can maybe go through the government system and receive subsidized care, but they're not as freely able to access as they ought to be. So yes, to answer your question, it depends very much on the context of where you're talking about. From a developed nation like Singapore, you have certain aspects, and from developing nations where there's maybe cultural reasons why women are not allowed or not as easily able to seek healthcare, they face those challenges.
Interesting contrast, actually.
Yes, it is. But both affect women's ability to receive healthcare, and perhaps at different extremes, but they are there and should be tackled. If we want to live in a society where men and women are given equal rights to receive healthcare, we shouldn't put those artificial exclusions on based on gender.
Absolutely, I agree with that. And so in terms of healthcare systems, so the UK and Singapore may differ greatly, and some prioritize universal coverage, whereas others rely on private payment models. From your personal perspective, what are the strengths and weaknesses of each? I mean, you could maybe compare a little bit.
Yeah, so those would be my natural comparators, because I worked for a long time in the UK and now working in the private sector in Singapore. I have those two direct comparators. There is a private sector in the UK. Most of the population will not routinely access private healthcare. They would preferentially go into the government system, which is called the National Health Service, or NHS, which is quite widely understood as being free at the point of use. So there's no financial transaction when you receive healthcare in most circumstances. And so individuals don't have to make choices based on cost, or the frequency of their visits is not based on how much they can afford to see the doctor. When they're given advice by their specialist or their GP about what treatment they should have, it's not factored in whether that is an affordable treatment or not at an individual level. But of course, those decisions have to be made at a governmental level. So top-down decisions made on how affordable a new treatment might be. If you extrapolate that into a population level, you say, okay, this costs X number of pounds per patient per year. Can we afford to introduce this into the National Health Service? And so there is a form of rationing in that sense. If you compare that to a system where you may have private insurance, rather than the government being the restrictor of what you receive, it might be your insurance company. So they might say, okay, you can only go to this provider, this hospital, or this specialist, which is on an agreed panel. Or they may say, okay, this treatment is not covered, it's excluded. Or they might say, well, you've had that condition before, and now it's happened again. Well, that's an exclusion on your policy because it's a pre-existing condition. So those are some of the challenges when you have a private system, is that someone somewhere wants to make a profit margin out of you. So it can be very good. You can have more choice, perhaps. You can have good treatment, but there are restrictions placed on what you get in other ways. So I think the universality of the NHS and similar healthcare systems in Western Europe, such as in Spain, perhaps in Finland, those systems which provide free at the point of use healthcare is to be aspired to. But it's a bit like, I think, when Winston Churchill said that democracy is the worst form of government apart from all the others. That it's a bit like that with universal healthcare. In theory, it's fantastic. Because it doesn't matter if you're a rich man, poor man, you receive ideally good quality care with zero cost to you directly. But the reality of providing that on a population level is very, very difficult. You also have the challenge of natural human instincts. So if something doesn't have a cost, it perhaps doesn't have a value. So you might not value the healthcare that you're receiving in the same way. So you don't know how much an individual appointment might be costing the NHS. You wouldn't have an understanding of that if you're not paying it out of pocket. So if you miss your appointment, it costs you nothing, but it does cost the healthcare system something. So those kind of inefficiencies can creep in. And just from the provider side, if I'm there as a doctor, if I request a test, I might not know how much that is costing to the NHS, and certainly it's costing nothing to the patient. So they're not questioning my decision about whether to have that test, because they're not having to pay out of pocket, and the government is not telling me how much, for example, a CT scan might cost. So I might say, well, let's repeat the CT scan that you had last year because we want to check something or other. But I don't know if that's a useful resource to expend or not. Or something simpler like a blood test. If you had a blood test done last month, then I might want to say, I just want to make sure it's all still okay. I don't know what that cost is directly. I've only worked in one hospital where on the electronic ordering system, next to the test, there was a little code to mark the price. And it's there as a prompt, a little reminder that every test you order does have a direct cost to somebody. The universal healthcare system is good, but very, very difficult to maintain the universal principles of it, being free at the point of use and efficient and providing high quality. Other systems exist, so you can have mixed systems where perhaps the government is not the payer, so it might be a private insurance system, a bit like in Germany perhaps, or in the Netherlands, where you have insurance systems through your work. So your workplace might pay for your insurance, or an employed person might require to have insurance. And then the provider is a private provider, but perhaps under certain regulations from the government. So that has a bit of a mixed system where perhaps you can increase efficiencies because you have a kind of business model behind it. People have perhaps a bit more autonomy to choose where they access healthcare. But it has its downsides as well. And then you'll have certain parts of the world where it's a pure out-of-pocket system, and that's common in the developing world, where there may not be an healthcare infrastructure that everyone can use. So you're paying directly for the healthcare that you receive. And in countries like in sub-Saharan Africa, poorer parts of Asia, you might have that kind of system. And of course, it relies on people having the money and the means themselves to receive, or to rely on perhaps charitable organisations to provide it for them. And therein lie other problems. So a charity often will have a particular niche area that they focus on. We see that with philanthropists such as Bill Gates, so the Bill and Melinda Gates Foundation, which has ploughed a lot of money into malaria research, which is one aspect, a very important aspect, but it's one aspect of healthcare in sub-Saharan Africa. So if you push all of your resource in one direction, you may then neglect other aspects of the healthcare needs of the society. And it's at the whim of an individual as opposed to an organised government system. So I think in answer to your question, what are the pros and cons of these systems? It's pretty apparent when you go into those systems as a patient, and when you work in those systems as a doctor, you know what the fragilities are, what the challenges are. And I haven't yet come across or worked in a system which is perfectly able to meet the needs of society without either saying rich man, poor man, or without having the difficulties of providing the needs of everybody who wants to access healthcare. So I can't pretend to have the answer. I think it was an ongoing challenge to find. And ultimately, it comes down to how much resource, money, individuals and governments are willing to put into our healthcare system, and what the priorities might be for that society.
Excellent. Thank you so much for that detailed answer. I mean, I'm learning so much through this conversation. It's brilliant. Thank you. Robin, okay, this is a personal question. Concept of choice in healthcare. It sounds empowering, but choice can sometimes overwhelm the patient. So how do you strike that balance between offering many options and guiding patients responsibly in your sector, for example, in gynecology?
Yeah, I mean, it's a great question, because that is a real challenge for us. So there may be patients that come into the consulting room that have already had a discussion with somebody else. They may have done some reading around the condition they have in the background at home. They may have opinions from friends or relations that have also got experience of that condition. And they may come with all of these different things in their minds. And then you have to try and navigate through what they already know, what your impression of their condition is, and therefore how you might recommend treatment, and get to the point where you find an acceptable solution to the problem that they've got. Now, I worked with a very brilliant obstetrician when I was in London, who used to say that it's not your job to give them a shopping list of different things to choose from. That's totally inappropriate, because, as you say, you do overwhelm patients. You can give them 10 different choices, but how do they make the decision?
Correct.
You're kind of absolving your duty as a professional person to just say, here, pick what would you like and I'll do it for you. That's not your job. Your job is actually, as doctor meaning teacher, it's to explain, okay, what are the pros and the cons of the different options, but also to make a recommendation. You say, in your circumstance, these are the options available, but I would suggest this one for whatever reason it might be. And then the patient is free to disagree and say, well, I've heard what you're saying. I understand why you've told me that, but actually that's not acceptable for me for whatever reason. I prefer to have this one instead. And that's fine, because we have to respect the autonomy of choice and the ability of patients to make a decision that you might not personally agree with. But as long as they've understood why you're making the recommendation and on what basis, then they can take the information as they wish. But yes, you're right. Choice can be overwhelming, and in society where you're bombarded with information and opinions on lots of different things. So you, for example, might look on Instagram and say, okay, I want to look up this particular condition, and then suddenly the algorithm will throw at you lots of different things, which can cause more confusion. And in amongst all of those information videos, there'll be some where they're trying to sell you something.
Yes.
And you have to be very mindful of that. So they can put a spin on things and make it all sound very impressive, but just be mindful where the information comes from and why someone is recommending a certain thing. And these are some of the advantages of having a government system which has no incentive to over-recommend treatments or sell you something that's a bit of a snake oil solution which doesn't work. Whereas, dare I say, in a private system, you're incentivized very differently. So you want your patients to have high quality care, but you want your patient to keep coming back, and you want them to also have a good relationship with you. So you don't necessarily want to disagree with them. So there's different incentives in different circumstances.
Fantastic. Thank you for that. I have a question that goes beyond the structure and finance now. It's about culture, because culture plays a huge role in how people approach healthcare. So can you share one or two examples where cultural context influenced the medical practice? Like any challenges that you may have faced along the way because of that?
Yeah, I think, so I've been working in Singapore for a little over a year. The medical practice and the education that the doctors receive in Singapore is very, very similar to the UK. In fact, a lot of doctors that work here may have trained either during medical school or subsequently in the UK or other similar systems. And so the practice is very similar, but how patients might access healthcare is sometimes different, and how acceptable certain treatment options are to patients might be different. So, for example, in Singapore, if you mention hormone treatment to some patients, they would be very reluctant to consider that. They'd say, hormones, no, not for me. And that might be based on their own experience or what they've understood from their friends, or just a natural bias against that kind of treatment. So that's a common scenario that we face, and then it's kind of unpicking what the concern is that they have with that particular treatment, and how we can maybe navigate through those anxieties or their concerns. So that's one example. Other examples are when perhaps parents come in to the consulting room, even with young adults, so not with children, but with young adults, the parents might come, and again, they have their own opinions on perhaps what's acceptable. In gynecology, we often prescribe the contraceptive pill, not only for contraceptive reasons, but also for heavy periods or painful periods, irregular cycles, polycystic ovarian syndrome. And so it's a drug that can be used for a multitude of indications. But if you sometimes mention that word contraceptive pill, then that can cause a bit of a concern. And so again, it's unpicking why that might be an issue, or what the implications you might be projecting, and how it's received. So those are some things which we face fairly regularly. And then there's a certain perhaps cynicism amongst the population of when you recommend certain treatments, especially if they're expensive treatments. So in the private sector here, surgical procedures can be very expensive. And insurance policies may cover a proportion, there may be a co-pay, or the patient may be uninsured. So they also want to know that you're giving them honourable advice, that you're telling them, yes, this is the recommended treatment and it's for your benefit. It's not for my benefit, it's not for the organisation's benefit, but this is why it's being recommended. So yeah, those are the considerations that we have, and it is about meeting the patient where they are. So I might be surprised when a patient reacts in that way and says, oh no, I don't want the treatment you're recommending. And then it's about trying to figure out why. And it will be sometimes horses for courses. There may be some patients that find that approach not to their liking. And then they have the ability to maybe seek healthcare from someone who's more on their page.
Fantastic. Thank you for that. So this is the next topic that I would like to broach is on healthcare ethics. And some people find it controversial, but I think with the rapid growth of personalized medicine nowadays and genetic testing, what ethical dilemmas do you think you foresee in how we screen fetuses or children with genetic risk?
Yeah, great question. So yeah, the question about fetal screening is very interesting, because the fetus in most countries will have no rights until birth. So all of the decisions about antenatal care and fetal care lie with normally the mother. So that is an interesting concept in itself, that you have to be clear that you're treating the fetus but via the mother when it's antenatal care. And that crops up when considering fetal interventions, which are increasingly available. So that's one concept. The other thing about genetic screening is that most women will want to know if there's an anomaly, an abnormality with the baby's development. And then they can make choices about the pregnancy, whether to continue or not. And if they continue the pregnancy, what implications does that have for the birth and afterwards? So the majority of women would want some form of screening in the pregnancy to check everything is as it should be. But then there's a deeper question is, okay, so if we screen this baby for every genetic potential abnormality, then how does that help? Does that actually increase anxiety? So this concept where you actually give potential bad news, it's not bad news, but that can have a negative impact on how the woman feels about her pregnancy. Are you helping or not helping in doing so? And then genetic screening for a population level. So you or I, if we took a genetic test which gave us a prediction of developing X condition in a few years' time, is that good for us to know? Or is that harmful for us to know? If it's a condition where we can make an intervention now and maybe prevent that from happening, so we could say, okay, we're at increased risk of developing diabetes in the future, for example. And we could say, okay, so we'll make some lifestyle modifications and we can perhaps either reduce our risk or delay the diagnosis. That might be helpful information.
Yes.
So that's part of screening. But then if we're screening for a genetic abnormality which we cannot prevent, we cannot maybe predict if we get it or not, then that might not be so helpful. And then there are broader aspects. Of population level, there are pros and cons. So the government or the healthcare provider might want to know that our population has an X percentage chance of developing a certain condition in the future. Why is that helpful? Because then the healthcare system can cater to that. So you can say there's going to be, in a few years' time, this number of patients that are likely to develop this condition. So we need to make sure that we train specialists in how to treat it, that we have the services set up and ready to help, and make all sorts of preparations in advance. So that can be very helpful. But sometimes it can be information that you don't want other people to know. You might not want your insurer to know that you're going to develop X condition in a few years' time, because they might decline coverage, or they might add it on an exclusion. So there's various aspects to that, and that's where the ethics comes in. So whose data is it, and for what purpose are you collecting it? And these are the principles of taking those type of tests. It's your data. So if someone is going to screen and give you some information, that shouldn't go beyond you and the person that's done the test for you, unless it's either anonymized, in which case the government uses that, but not with individual names attached. Useful, but then going to a third party who might not use that data for your benefit, not useful. Not useful. So yeah, for looking forward to how we might take genetic screening tests, those are the dilemmas that we will face. And for a fetus, again, if you're an adult and you receive some health information, you might not want to share that with your parents, for example. But when you're a fetus, your parents are going to be the ones that are told that news. So if it's an important condition to detect in the pregnancy, or perhaps in childhood, yes, might be appropriate. If it's something that's going to lead on to an adult condition, maybe it's not. Perhaps. It's an argument worth having, isn't it? Whether that data should be shared with your parents at the time when you're still a fetus, or whether that's your data to receive individually at some point in the future.
That's interesting. That's very interesting. For another topic, I think.
Yes.
Yes, perhaps. So that actually leads on to artificial intelligence and big data management. There is a lot of promise. There are major advances in healthcare to do with AI and healthcare. So from a personal point of view, what excites you most about that field? And what worries you about these technologies? Could you, the future role of these technologies, perhaps, in medicine?
So when we use the term AI, I suppose it's important to know what aspect of artificial intelligence you refer to, because it can mean different things to different people in a different context. But in healthcare, I think we have to accept that AI is here already, and it's going to evolve, obviously, in the future. But patients will routinely ask ChatGPT, what is causing my symptoms and what should I do about it? So we have to assume as doctors that patients have already done that. Before they walk into the room and tell you about their symptoms, they've already checked themselves. So you're up against the AI as a kind of competitor in terms of your brain power to think, okay, what is the diagnosis here and what are the recommended treatments? And so you have to be on the ball, really. You have to know what they're going to know already about their condition.
Right.
If you give a plan which is at odds with what AI might have told the patient, they're going to perhaps lose their confidence in you, because it's easy to have trust in a computer system. It's harder to have trust in a human, arguably. So that they're coming from that position. Now, AI as a healthcare provider potentially provides you with a lot of resource, because it might help you in diagnostic accuracy. So AI can be used in radiology departments to detect abnormalities in x-rays and scans. It might be able to detect abnormalities in pathology samples in
Mm-hmm.
the laboratory as well. And so it might replace certain human roles if it can increase the accuracy of detection of abnormalities. So that's not to be feared. In fact, that's to be encouraged,
Mm-hmm.
because one of the issues, going back to the Pap smear, one of the issues with that is the discrepancy or the disagreement. So you and I can look at the same sample and come up with a slightly different conclusion. It's unlikely that I would say it's cancer and you say it's normal, but there's a scale of abnormality that AI might be able to help improve, that kind of thing. So AI is to be welcomed in that setting. The other things that AI, not glamorous things, but AI can also help if you're maybe seeking out patients, again going back to screening, seeking out patients that haven't come for their screening test. So you might deploy AI into your system, your computer database of patients, and say, look, who hasn't come for screening and why?
Mm-hmm.
So it's not just doing a little audit trail of your computer system to detect and send them all a letter and say, come along to clinic. They haven't come already. So there's something maybe about them that they're not coming. So do they respond better to a text message compared to a letter?
Mm-hmm.
Can they read? Can they read it in the language that you're sending the information in? Is there another way that you could invite them?
Mm-hmm.
Have they expressed fears about certain other healthcare interactions that you might be able to address? So AI can be used in that way. Other complexities of medicine which that humans will always struggle with is interactions of medications.
Mm-hmm.
So newer drugs coming on the market that we discover how they work and how they might alter the actions of other medications. AI can be used in that sense. So if I prescribe a drug and I can list out the other drugs that the patient is taking, perhaps AI can say, oh, look, you might not want to mix that drug and this drug, or you might want to alter the dose or what have you. So that role, which is normally taken on by pharmacists, can be enhanced, I'm sure, by AI, and detecting patients that are maybe taking medications that are not suitable for their condition. So in answer to your question, it depends how you deploy it.
Mm-hmm.
But AI, I think, is here to stay. It will be with us, and it's about harnessing that power for the benefit of our patients. So not expecting too much, I think, at least in the initial stages. It can't replace the human interaction. AI won't really be able to do precise tasks like surgical procedures as well as a human can, because you're making judgment calls all the time with those kind of things.
Yeah.
But with diagnostics, I'm sure it'll be helpful. With research, I'm sure it'll be helpful. If you can scour the world's research on a certain condition with a machine that is just set forth, that's going to be much more efficient than trying to do it yourself. You cannot possibly keep up with the amount of research which is published on an annual basis as an individual person, or even as a huge team of people. So if you set a machine on that task, that can be very beneficial. And things like rare diseases, there might be a disease that crops up once in a million. And so over the world, you'll get quite a number of cases, but in an individual country, you'll get very few.
Mm-hmm.
So things like that you can envisage. And there's also been examples where it's been used to maybe predict the efficacy of a new drug. So you can run it through perhaps a program which can say, no, this is likely to be effective, this is not likely to be effective. So you can kind of target your research in that way. So yeah, I think AI is not a negative for healthcare, but it has to be used in a way which benefits our patients.
And it has to be a transparent model which leads to the human in the loop, always making the ultimate decision.
Yeah, absolutely. So I can't sit there and plug in my patient's symptoms and then ask AI to give me a treatment plan, because you completely exclude the patient from your treatment plan then, don't you? So no, it can't be done in that way. And it can't be done vice versa. It can't be done where the patient is at home on their computer and asking the AI machine to tell them what their diagnosis is, and then walking into the consulting room and saying, I'd like this treatment, please, because AI told me that's what I need. So yeah, you definitely have to have the human interaction maintained. But in terms of not missing unusual diagnosis, surely that's a good thing. recommending tests that are going to take you forward with the diagnostic pathway as opposed to distract you in other directions, definitely helpful. So yeah, I can see good things happening with AI when it's used to its best potential.
Thank you. Excellent, Robin. This leads me to the next one, which is about population age. Balancing care for the elderly while not neglecting the younger generation. So that means how can healthcare systems navigate this ethical and practical challenge of balancing elderly care and also looking after the younger population?
That's right. So it's interesting you put it that way round, isn't it? So you prioritize the elder population over the younger population, or perhaps you prioritize the younger over the elder. Does it have to be split like that? Do you have to have the either or? Well, hopefully not. So I think what we have an aging population. We have a healthcare savvy population, one that's been used to receiving high quality healthcare their entire lives. So individuals in their 70s and 80s now approaching the final years and decades of their life will be used to seeing the doctor if they have an ailment, and they'll be used to having a recommendation of a certain treatment. So you can't say at a certain number of years of longevity that, okay, you've had your healthcare now, it's time to just sort of disappear quietly into the corner and not come to hospital anymore. You can't have that system. And equally, you cannot not invest in your young people because they're your population of the future. And arguably, the interventions that you put in place in childhood are going to reap a lot more reward for your society, because the years at which that person then maintains good health is going to be many more. And that's where the concept of the QALY, or the quality adjusted life year, comes in. So the intervention or the resource that you allocate to a certain individual has to then pay back in terms of quality of life, not just longevity of life. So if you're improving the quality of life of an 80-year-old, that's just as valuable as if you're improving the quality of life of an 8-year-old. And I don't think it is an either or. It cannot be an either or, because then you force a decision. You have to force a decision onto your society to say, okay, we value older people. No, we don't. We value younger people. And you have to value everybody in your society. Okay, otherwise the healthcare system cannot function. You can't ration in that way. But it's about also being responsible with the resource that you have. So having a general societal agreement as to how you run your healthcare system. Is it an individual-based system? So those with the best ability to pay or to access healthcare get the best, or is it spread across the whole of society? So you don't have those individual ability to receive better healthcare, that everybody has the same. And that's for every society to decide, and every society to navigate, because there is no perfect system, as we discussed before. But there are certain things that have been tried in some societies where you have a mixed living. So you might have an older people's living facility, so it might be an old folks home type setting, and then you maybe mix with students. So you might have student accommodation, which is either shared or nearby, and then you can mix your population. So it's not seen as us and them. Everyone has a role to play. So the students might, in return, they might receive low-cost accommodation, which might suit a student budget, but they also have certain expectations that they will interact with the older folks there as well. So there's various ways that you can integrate societies without anyone suffering.
Fantastic idea of mixing the elderly with students, and that also has a beneficial effect on the lifestyle and perhaps the lifespan of the elderly person.
Yeah, for sure.
Yeah.
I mean, it must improve quality of life if you're having more social interaction in your twilight years. And for the students, it means they have an acknowledgement that they will be there one day. So you can't write people off, and you can't say, okay, that's not my problem. It's everybody's. So and again, everyone has to decide how that might work in reality.
Yes.
In Asian cultures, often the family will take on the role of caregiver to the older members of the family. and that can work very well, but it does place a burden and some dynamics within each family. And so how much the state wants to get involved in that responsibility versus the individual family unit, again, is very dependent on the culture.
Thank you for that. Yes. So my ultimate question today, this has been a really fascinating conversation. Thank you so much for your time. Looking ahead 10 years ahead, if you could redesign healthcare from scratch, what key principles or structures would you prioritize to ensure fairness, sustainability, and patient-centered care?
Thank you for the question and the challenge. I'm not sure I have the answer to that, which is going to be a perfect solution. I think, in terms of access to healthcare for everybody, the principle of universality has to be in there somewhere. So otherwise, you are making judgments over someone being more or less worthy to receive healthcare, and I don't think that should be an underpinning of the healthcare system. It may be the reality of how society is structured. We can't all live in a mansion. We can't all drive a very expensive supercar. We can't all eat in Michelin-starred restaurants every day. So there are some realities where some people will have more material wealth than others, and that is reflected in lifestyle. And if you have a system where healthcare can be accessed through monetary exchange, then of course you're going to have that. But even if you have a system where you can pay to receive good quality healthcare, that shouldn't be at the expense of the poorest of society. So you shouldn't neglect those that don't have that material wealth or resource. So I guess that's one of the underpinnings that I would be keen to see, is that everyone is able to access healthcare. In terms of sustainability, that can have several meanings, can't it? So sustainability means that you want to ensure that your healthcare system continues for generation after generation. So you don't just blow all of your budget on one generation and then there's nothing left for the next. So that's one aspect of sustainability. Then there's the more kind of modern concept of being green and environmentally friendly and not having, for example, single-use surgical instruments where you manufacture something of such complexity, use it for one operation, and then it gets thrown away. That cannot be sustainable. Our populations that follow ours in 1,000 years' time, who may be doing some archaeological dig, we would not want them to dig up lots of perfectly usable surgical instruments and say, I wonder what they used this for, and I wonder why they threw it away, and I wonder why they became extinct. So I think we have to be mindful of the cost, both monetary and environmental, of providing healthcare, and that's part of sustainability. And then, in answer to your question about resource, I suppose how do you provide all of that within the budgetary constraints of life, and that comes down to how much you want to make healthcare a priority, and every society will have a slightly different view on that. Do you value longevity over quality? Do you value the certain aspects of treatment? For example, cancer treatment often gets a lot of attention. If you want to raise money for a charitable cause, you might want to put a child's charity up there, because that will generally get more attention than one for dementia care, which generally gets a bit less attention. So yes, you have to then decide how you're going to provide for the needs of everybody. So yeah, I don't have the solution. I don't think any of the systems I have worked in or currently work in have that solution. But we do our best as individuals to provide for our patients in the context of which we work. And that's at the heart of medicine, and always has been, I think.
Yes. It's aspiring to deliver that sort of healthcare system to the patients.
Yes, I think so. I think so. So doing the best for the individual in front of you, but also the broader society. Yes. And going on that journey, healthcare is an evolution, isn't it? And so we hope that we progress for the benefit of everybody, but we live in the real world.
Thank you so much, Robin. That was a delightful and really insightful conversation today. Thanks for your time and all your anecdotes. I hope to have another conversation with you in the near future regarding healthcare.
Sure.
So thank you very much for
Thank you.
coming along today. Thank you for joining us for our healthcare podcast. Please join us for future healthcare podcasts where we'll be interviewing entrepreneurs and healthcare specialists. In the meantime, please link in with me on LinkedIn. Thank you.